Hello, hello. Are you guys able to hear me? Hello.
Yes, we're here. Good
Okay,
morning.
okay, that's great. Good morning. So, Dr. Moaz is here in the session. He wanted to continue the session today. He is here, and today the session is going to be conducted by Dr. Moaz. Okay. 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 Let's wait for Dr. Moaz. He's here. Okay.
Hey guys, how are you? First question I wanted to ask: how many more days of hematology have you done, guys? Mm, just give me 1 second. No, not now. I'm not. Just give me 1 second. Can you, do you guys know till where you have studied the hematology on
We did platelets.
Okay, platelets. I don't. I think we completed platelets on our own. No.
Sir, you can start from lead poisoning.
Lead poisoning. Okay.
Yes.
Did you guys do macrocytic anemias?
Yes.
Okay, and let me check. What about normocytic anemias?
No. Only iron deficiency and thalassemia.
I think we just barely started those the microcytic. We just started it, so I think we did microcytic and
Oh,
thalassemia and something like that.
yeah, I think microcytic we did together. Did you do any anemias with Dr. Ahmed?
No, no, he just
No.
gave us a basic intro of the
Yes,
macrocytic, but we didn't do macrocytic anemias either in
that's
detail.
correct. That's correct. We just barely started it. Just intro.
Okay, let's start from the normocytic first. So the one other kind of anemias are the normocytic anemias, right? So normocytic anemias mean that the MCV is gonna be normal, right? This is the main thing regarding normocytic anemia is that the MCV is gonna be normal. And these anemias are very important because normally they are very hard to pick up and you cannot pick them easily, right? Because a lot of people are gonna come with normocytic anemias in your real life. So how do we pick them? What are the main features of these anemias, right? So first of all, the first thing is that if a person comes with anemia and the MCV is normal, that is the MCV is between 80 and 100, then it means that it is a normocytic anemia, right? And the majority of anemias in the real life are going to be normocytic anemias, right? Now, the second thing that is important is the fact that we classify the normocytic anemias into two types. One are the hemolytic type. So, what are the hemolytic anemias? Hemolytic anemias are such anemias in which the red blood cells are gonna get destroyed. Right. So in hemolytic anemias, red blood cells get destroyed, whereas in non-hemolytic anemias, red blood cells do not get destroyed. So basically, this is the major difference between hemolytic anemias versus non-hemolytic anemias. Right. So further, okay. So is everything clear till now? So this,
Yes.
mm, okay. So this was the main thing, right? Now, when red blood cells are gonna be destroyed, they become very low in the body, right? And when they become very low in the body, what is gonna happen is that you are gonna have anemia. Basically, this is the normal understanding of anemia, right? Just give me 1 second. Okay, so right, so these are gonna surpass the normal life. So see, so now red blood cells can be destroyed. So we have two main spaces in our body. This is a very important thing that you guys need to understand. We have two main spaces in our body. One is the red blood vessels, right? First of all, we have the blood vessels. Right? And outside of the blood vessels, we have the tissue space or the interstitial space, right? And there we have and outside of the interstitial space are tissues present, right? And this area is empty. All of this area is empty, right? So basically, the place that is present between here and here, it is known as the extravascular space, right? And even the tissue is also known as extravascular space. So if any hemolysis occurs inside the blood vessel, then we call it as an intravascular hemolysis. Whereas if a hemolysis occur outside of the blood vessel, we call it extravascular hemolysis, right? Now, for every anemia, we have some basic workup, right? So, for example, if any iron deficiency anemia comes in, our main workers is gonna be TIBC and ferritin and reticulocyte count. This is the main thing that will do. So remember these workups, right? For macrocytic anemia, we have further workup as well. But right now we are going to discuss the workup of hemolytic anemia, right? So for hemolytic anemia, the first thing that we are going to do is whenever a patient with normocytic anemia comes to you, you want to see if the patient is having hemolytic anemia versus non-hemolytic anemia. And how do you see that? In order to see that, first thing that you do is order an lactate dehydrogenase. So first thing you order an LDH. The first thing that you do is order an LDH, right? Why do you order an LDH? Because LDH is a marker of red blood cell destruction, right? Right. So you have to order this thing, right? You have to order LDH. When you order LDH, then if the LDH is elevated, it is gonna show you that the red blood cells are destroyed. There are other conditions in body that also destroy LDH, right? But remember, LDH 1 and 2, there are five kinds of LDH, right? LDH 1 and 2 are present in red blood cells also. They are also present in heart, kidney, skeletal muscles, etc. But LDH is a good marker of these things, right? So you can rely on LDH for these things. Okay.
Sir, LDH is the marker of red blood cell production or destruction.
Destruction. So, okay, so basically, let me tell you the marker thing, right? Every cells have different proteins, right? Every cells have different proteins, right? And when those proteins get destroyed, right, you are gonna see that there is an effect of that is coming upon, right? When the cell gets destroyed, the protein comes in the blood, right? So if there is a cell, right, or if the cell is present in the blood, right, and if there are hundreds of proteins inside the cell, right, as soon as the cell gets destroyed, this protein comes out, right, and when this protein comes out, the amount of that protein in the body becomes high, and we know, oh, this cell is getting destroyed, right? So red blood cells have LDH, right? When red blood cells are gonna get destroyed, right? So when our red blood cells gonna get destroyed, if the patient is having hemolytic anemia, then LDH is gonna be elevated, right? Similarly, Similarly, another example, I'll give you another example. Heart muscles have, this is a heart muscles have creatine kinase, right? Troponins, this is a protein, right? And they have LDH as well. So you're gonna see there when a person is having heart attack, their CK is gonna be elevated. Their troponins are gonna be elevated, and their LDH is gonna be elevated as well. Right, so all of these things are going to be elevated in patients who have what do you say, red blood anemia, right, hemolytic anemia. Is that clear, guys? So this is the first thing that is going to be elevated in these patients. Second thing, these patients are going to have bilirubin levels increased. Unconjugated bilirubin is going to be increased in them. Again, it's very simple, right? When you destroy red blood cells, right? Red blood cells have heme inside them, right? Red blood cells are bilirubin, and that is gonna be increased, right? Increased hemolysis is gonna cause increased amount of unconjugated bilirubin, right? Is that clear, guys?
Yes.
So this is the basic markers. Now we are gonna move to the advanced stuff, right? And what is the advanced stuff? So we have two types of hemolysis. One is the intravascular hemolysis, right? And the other one is the extravascular hemolysis. Okay, what's the difference between them? I'll go on one by one, right? So for intravascular hemolysis, the red blood cells are present. Right? So for intravascular hemolysis, red blood cells are present inside the cell, right? Red blood cells are going to be present inside the blood vessels, right? And they're going to get destroyed from there. So how can something get destroyed from intravascular hemolysis? This is an important thing, right? So we are gonna go to them one by one. What are the conditions that can cause this thing, right? First thing is that we have discussed this already. If a person has, for example, an antibody against red blood cell, right? So there are antibodies against. What is the condition in which we can have antibodies against red blood cells? Anyone?
Autoimmune hemolytic anemia.
Anything else? Yes, that's true. One is autoimmune hemolytic anemia. Anything other?
PNH, microangiopathic hemolytic anemia.
Yeah, but what's the most important one? The most important antibody mediated condition.
CCP is also there.
Hmm?
HS.
It's not written in New World. It's not written in first
Is
year.
it a clause?
Uh, it's not written in first year, guys.
It's
Wait a second, I'll
TTP.
note it.
TTP.
No, no, like antibody mediated red blood cell destruction. Purely antibody.
Just asking, she said,
The SLE, in the SLE,
Mm-hmm. Yes, SLE is one. SLE is important. SLE is the one condition. I'll tell how it causes that. In anything else too?
Even in CLL,
Mm-hmm. Anything
weak
else?
level.
Does it have anything to do with IgA transfusion?
Basically, blood transfusion reactions are very important, cause.
Yeah.
I'll turn it off for her. I'm gonna log in and turn it off. I'm gonna log in from there. Oh, it didn't. Okay. No. So, like, tell me. Okay. So basically, the most important one is acute hemolytic transfusion reaction, right? The one that we have discussed already. Acute hemolytic transfusion reaction. That is the most important thing, right? So, what is gonna happen in acute hemolytic transfusion reaction? A red blood cell is gonna come inside the body, right? When red blood cell comes inside the body, right? There are gonna be antibodies that is gonna be produced against them. Antibodies are gonna be present against these red blood cells. And they are gonna destroy the hell out of this cell. Right? They will destroy this cell. Right? And when this cell is destroyed, right, you are gonna get intravascular hemolysis. That is the first condition, and that is the most important one, right? Now, regarding intravascular hemolysis, another thing that is very important is that when you inside the blood vessels we have a thing which is known as this is an important marker. So now, uh first thing, you look at a question, you see the the MCV is normal, right? You are good, right? So you know this is a normocytic anemia. Now what is the second thing that you look for? You have confirmed this is a normocytic anemia. What is the second thing that you guys look for?
Grandes?
No, so the second thing that you look for when a person has normocytic anemia, it
serum
just
iron.
Hemoglobin.
just give me 1 second, guys. Okay, guys. So I told you again. First thing, so whenever an anemia comes, the first thing that you look at is the MCV. If the MCV is low, it's a microcytic anemia. If the MCV is high, it's a macrocytic anemia. If the MCV is normal, it is a normocytic anemia. Right? Now, this is confirmed that this patient is having a normocytic anemia. What is the next thing that we look at? So the next thing that we look at is this. So this is confirmed that this is a normocytic anemia, right? What is the next thing that is important, right? The next thing that is important is you have to see if this patient is having hemolysis or not. And I told you what is the most important marker of hemolysis? It's the LDH. Lactate dehydrogenase is a very good marker of hemolysis. So if lactate dehydrogenase is elevated, it means it is a hemolytic normocytic anemia, right? It means that the red blood cells are getting destroyed. Why am I telling you this? Because there are specific diagnoses of non-hemolytic anemia that you can easily pick up and you can know. So there are only two non-hemolytic normocytic anemias. Only two, right? So for example, if the LDH is normal, it's gonna be very easy for you guys to pick up what is the condition, right? But if the LDH is not normal, if the LDH is increased, then it's gonna be hard for you to pick up. So that is why first thing that whenever a patient with homocytic anemia comes, you have to look at what is the problem that this person is having. Is it a hemolytic or a non-hemolytic anemia, right? So with that, we are gonna move to one of the most important topics of this chapter, right? So those topics are basically the hemolytic anemias, right? We'll start from the first one. The first one is hereditary spherocytosis, right? You guys have any idea about hereditary spherocytosis? Anyone?
The RBCs become spherical due to
Mm-hmm.
which
In
Uh-huh.
that, the cytoskeleton of the RBC is actually defected. That protein is actually defected.
Yes. So
Second
we'll
and
go
right.
into so basically, okay. So let's go. So the first thing yet the most important one is hereditary spherocytosis, right? So what happens in hereditary spherocytosis? Did you have class yesterday? I think not with me, maybe with Dr. Ahmed, right? Okay. So basically, yeah. So the first thing that is important in hereditary spherocytosis is in hereditary spherocytosis, RBC protein. So basically, our red blood cells have a membrane, right? So basically, this is the membrane of red blood cells, right? So what is going to happen in the hereditary spherocytosis is that we have two proteins. One protein is known as the spectrin protein. The other protein is known as the ankyrin protein, right? So in hereditary spherocytosis, these proteins are gonna be defective, right? So when they are gonna be defective, right, the shape of red blood cells is gonna be like this now. It's gonna be changed, right? And when the change of red blood cells are gonna be changed, what is gonna happen is that red blood cells are not gonna be able to move. So basically, red blood cells are like this. They are very flexible, right? If this is the blood vessel size, right, and red blood cells are like this. Do you know how red blood cells pass through it?
Amoeboid movements.
Yeah, basically they squeeze in, right? Their membrane has a lot of elasticity, right? So it's very easy for the red blood cells to squeeze in and go through it. Right? Just give me 1 second, guys. Okay, so guys, so basically red blood cells, they are gonna pass through this easily. But when suspectin and incarin is not working properly, what is gonna happen is that this red blood cell is gonna get trapped here as this, right? When they are gonna get trapped, right? Now the thing that you world and NBM is love to ask you is that a lot of people know this already, but the most important thing that they ask is where is the red blood cell gonna get it trapped, right? There are a lot of blood vessels in the body. Which blood vessels specifically red blood cells get trapped into? Any idea?
Capillaries.
Spleen.
Subclinic
Spleen.
arterioles.
So basically
What?
spleen. So when red blood cells are gonna go to the spleen, right? Whenever they go to the spleen, they are gonna get destroyed there, right? They are gonna get trapped there, and when they will be trapped there, they are gonna get destroyed, right? Second thing is that they are gonna get destroyed. They are gonna happen. Two things are gonna happen, right? First thing, spleen destroys red blood cells. Spleen is gonna get enlarged. So first thing you are gonna have is splenomegaly. This is a very important, right? Why is this important? If they give you a question with anemia, especially hemolytic anemia, and the next thing that they ask you is a patient is having uh, with hemolytic anemia, they ask you next thing that the patient is having splenomegaly. What is the thing that should come into your mind, right? What is the thing that comes into your mind, right? The thing that comes into your mind is hereditary sepinocytosis, right? So there is a triad of hereditary sepinocytosis. I don't know if it's written in the U world or not. First thing, anemia, right? So anemia, splenomegaly, then the next one is jaundice, right? And the last one is gallstones. This is very, very, very specific for hereditary spherocytosis. You are not going to see any other condition in which there is going to be anemia and splenomegaly and gallstones. These three usually do not occur together, right? Right. So these three do not occur together. If these three occur together, then it means that this is a hereditary spherocytosis anemia, right? So that is the first thing that is important, right? Now there are some other things as well. How do we check? So first screening is how do we treat it? So I told you where are these guys getting destroyed? All of these red blood cells, spleen.
Spleen.
So we'll just remove the spleen. We'll just do a splenectomy, right? Now regarding splenectomy, one important thing that comes into my mind: if you remove the spleen of these guys, what three infections could these guys have?
H. influenza. Pneumo.
Influenza,
Neisseria,
GDC.
strep pneumonia.
Yes, yes. So how do we prevent them?
Vaccination within 2 weeks.
Vaccination.
Vaccination.
Within 2 weeks
Like after splenectomy.
after splenectomy, when?
You can do up to for 2 weeks and just
Yes, so
vaccinate.
basically you start it after 2 weeks of splenectomy, right? And or 2 weeks before, right? So you start it 2 weeks after or 2 weeks before the splenectomy. The next thing that comes into my mind is one other thing that is important is that is specific to this anemia is that in this anemia, red blood cells become small. When they become small, they have almost all of the red blood cells have a pallor in the center, right? So basically, this pallor is gonna get ended, right? They are gonna get end. The pallor is gonna go away, right? They are not gonna have any more pallor, right? And their MCHC is gonna be increased, right? So what is MCHC? Anyone? Yeah. So basically, it means how much hemoglobin. So if a cell is 100, if a cell has 100 kilometers of an area, just for example, right? And if a person has 50 kilometers of hemoglobin, right? It means that the mean corpuscular hemoglobin is 50 divided by 100, right? So it is 0.5 or 50%, right? So patient is having 50% of mean corpuscular hemoglobin. So why does the hemoglobin increases in uh, hereditary spherocytosis, the hemoglobin concentration? So what is going to happen is that the hemoglobin is going to be this much, right? It's going to be this much, but all of a sudden the cell is was this before, right? So hemoglobin concentration was very less, but now the cell is gonna get reduced to this amount. So hemoglobin concentration regarding to the cell is gonna increase massively. This is down. Yes. So this is known as the mean corpuscular hemoglobin increased, right? This is what we mean by increase of the mean corpuscular hemoglobin, right? Now, what are the tests? The tests that we do are very simple, right? There's a test which is
Please,
known
can
as
you
the
take it again? Please, can you take that mean corpuscular hemoglobin concentration explanation again, please?
Yeah, sure, sure. So one thing regarding concentrations that you guys need to remember is that there's a difference between concentration and amount, right? Consider this thing always when you are solving a question. There's a very big difference between concentration and amount, right? What does that mean? Okay. If this is a glass of water, right? And if it's filled this till here, right? And I put 100 gram of sugar in it, right? How much sugar are we having in the glass?
100 gram.
100 gram.
Mhm.
What would you call this? Amount or concentration?
100 plus is amount.
Amount.
This is
Amount.
amount, right? So
That is
what if I pour a, if I fill the water glass up till here? What now? What will be the amount of sugar now?
Still,
still
still
100. Still
Same. And what will be the concentration of sugar?
will be decreased like
It
50.
will be decreased. So
100.
this is the concept of concentration. So if this is a red blood cell and we have this amount of hemoglobin in the center, right? And then red blood cells, due to loss of spectrin and carrin and band 3 proteins, reduced to this much amount, and the hemoglobin is still the same. Where will be the concentration of hemoglobin higher?
High.
Where, guys?
In smaller
Smaller one. That is why MCHC increases, mean corpuscular hemoglobin concentration increases in hereditary spherocytosis, right? This is the concept, right? Now, one other thing is that you are gonna have the test is very simple, right? You're gonna decrease, this is a very new fancy test, 5 eosine maleamide binding test. So 5 eosine maleamide binding test, right? Okay. So we're gonna have 5 eosine maleamide binding test, and that test is gonna be positive. Okay. This is the second thing that is important. Okay. Any questions till now? This is the first hemolytic anemia that we did. Any questions, guys?
No questions, but not to take you back. Earlier, before you started talking about this, we were trying to differentiate between intravascular and extravascular
Yeah,
hemolysis.
so I'm just going to give you an example. First I'll let you know because this was an extravascular hemolysis. I'm just trying to tell you how does the extravascular one works, right? And then we'll move on to the intravascular one, right? So this is an extravascular. When you get the pathophysiology, then it's gonna be easy, right?
Okay.
So now, what is 5 eosinamide baleamide binding test, right? So basically, there is a dye which is known as the eosin 5 maleamide, right? Eosin 5 maleamide. This is a dye, right? And this dye goes to bind to spectrin band 3 and chitin, right? So it binds to spectrin band protein and encarin, right? Now, if the spectral band 3 protein and encarin are not working properly, this news is gonna bind less, and this is news is known as the eosin 5 eosin maleamide binding test, right? 5 eosin maleamide binding test means eosin 5 maleamide is not gonna bind properly, and you're gonna see that thing, right? So this is how we do that. Another thing is that these red blood cells become like spherocytes, right? So this is known as the hereditary spherocytosis. And if you look at the blood smear of these patients, there are going to be spherocytes that will be present there as well. Okay, guys. So basically, this is the whole treatment and the way that we do this thing. Okay. Any questions?
No,
Okay. Good.
Dr. Moaz,
Mm-hmm.
which one is confirmatory test for hereditary parasitosis? Is there anyone?
eosin 5 milliamide binding test. We use that one now. First we use another test, but now that's mean that we don't use anymore, right? Okay. Next one is the PNH, paroxysmal nocturnal hemoglobinuria. Right. So what is PNH? Right. So basically, what happens in PMH is that we have a thing which is known as the GPI. This is the GPI anchor, right? So what is the GPI anchor? This is important, right? There are a lot of questions on this as well. Every hemolytic anemia has a very characteristic feature that makes it different from the other ones, right? It's a very different. So GPI is basically glycosyl phosphatidyl inositol anchor, right? So glycosyl phosphatidyl inositol anchor, right? So what happens is that this whenever this anchor GPI, so basically if this is the red blood cell, this is the GPI. GPI is like antenna of red blood cell, right? So it's known as the glycosyl phosphatidyl inositol. I'm not. I'll if you want, I can go into detail of GPI anchor, but I don't think so it's necessary here. The only thing that want you do want to remember is that glycosyl phosphatidyl inositol is gonna bind here, right? And when it binds here, the next thing that is gonna happen is that it will bind two proteins, right? Right? It will bind two protein. One will be known as the CD55 or DAF protein, right? The other one is gonna be CD59 or miral protein, right? Right? So this is known as the decay accelerating factor. This is known as a membrane inhibitor of reactor lysis. Right? Basically, both of these proteins prevent red blood cells to be broken down by any complement thing. Right? Red blood cells, they allow red blood cells to be broken down by any complement thing. Right? So this is the first thing that is important. So now what happens is that sometimes there's a mutation in the GPI protein. So basically, the GPI protein does not function properly. It does not bind these things, right? So when it doesn't bind this thing, complement is gonna come, and complement is gonna destroy everything. It's gonna destroy everything of red blood cells. Red blood cells are gonna get destroyed, right? And then again, you are gonna have anemia, right? You're gonna have jaundice as well, right? Because unconjugated bilirubin is gonna be increased, right? And you're gonna have hemoglobinuria. What is hemoglobinuria? Hemoglobinuria is basically means, right, that basically when red blood cells are gonna okay, so where was so now I'll come on to the difference between intravascular and extravascular hemolysis. What do you think? Where was the problem happening in case of hereditary spherocytosis? Was it inside the cell or was it outside the cell?
Inside the cell.
Oh,
Outside.
I mean inside
Problem
the
was
blood vessels. Yeah.
Inside the blood vessel.
Anyone else?
No,
What do
it's
you think?
extravascular. It's extravascular
it
because
was
Yeah,
extravascular.
extra.
there is
So
Result
splenomegaly.
is
yes, so basically it happens
Extravascular.
inside spleen, right? It's not happening inside blood vessels, right? It's gonna go out in the spleen and then it's gonna get destroyed. So it's an extravascular source, right? Whereas in case of paroxysmal nocturnal hemoglobinuria, it's gonna happen inside the blood vessels, right? So what is the difference? So when it happens inside the blood vessels, the red blood cells, whenever they get destroyed, right, they are gonna release their hemoglobin. Right? Whenever red blood cells get destroyed, they are gonna release their hemoglobin. Okay. When red blood cells get destroyed and they release their hemoglobin, right? This hemoglobin is gonna go to the urine as well. So when this hemoglobin goes to the urine, right, we are gonna have hemoglobinuria, right? We are gonna have hemoglobinuria, right? Whenever this red blood cells destroyed and the hemoglobin that is released, it will go to the uh, so basically, it will go to the urine, and the urine is going to have a red, darkish, urinish color, right? So that is why a characteristic patient of paroxysmal nocturnal hemoglobinuria is gonna present to you with morning pinkish morning urine, right? So if they give you an anemia and they say this patient is having pinkish morning urine, right? And this patient is having increased amount of LDLs, right? And if they give you a urine analysis as well, and the urine analysis is positive for heme in it, right? Then it's gonna be sure that this patient is having paroxysmal nocturnal hemoglobinuria, right? Second thing is that this condition, in this condition, one other thing that is very common is the fact that these patients also start to develop thrombosis in unusual places. Right? These patients get thrombosis in a lot of unusual places. And when you have thrombosis in a lot of unusual places, right, with anemia and again with hemoglobinuria, then it's a diagnosis of PNH, right? Okay, so
What
yeah,
predisposes these patients to uh, thrombus?
okay, let me tell you, just take this at first. Okay, so first of all, we'll have to look at, but uh, first of all, we have to look what are the places of unusual thrombosis first. Okay, so sorry, right, right. So basically, whenever you get hemolysis, especially intravascular hemolysis, right? Okay, so whenever you are gonna get hemolysis, right, it's gonna generate hemoglobin, right? Okay, hemoglobin has a special property. So if it's the blood vessel, right, and hemoglobin is getting destroyed and coming out, right? Hemoglobin has a very special property. And what is that property? It attracts nitrous oxide to it, right? It attracts nitric acid, nitrous oxide to it. When it attracts nitric oxide to it, what will happen? What do you think is gonna happen? The thing that is gonna happen is that nitrous oxide in the body, will it be reduced or increased then?
Reduced.
Yes, so
Reduced.
hemoglobin is going to take all of the nitrous oxide. So nitrous oxide is going to be reduced. What is the main function of nitrous oxide in our body?
Vasodilator.
The first is
Yes.
dilated.
So now when if hemoglobin is increased and it is pulling all the nitrous oxide in it, what will happen to the bodies? Will they constrict or dilate now?
Constrict.
Constrict.
So body is going to vasoconstrict, right? This is going to cause oxidative stress in the body, right? Whenever there's going to be stress, whenever body goes to stress, platelet formation is going to increase, platelet aggregation is going to
Sir,
increase, right?
Dr. Moss, can you please repeat the concept of NO?
Yeah, sure. So basically, whenever red blood cells get destroyed, they secrete hemoglobin, right? Hemoglobin is present inside them, hemoglobin is going to be spitted out of them, right? And when hemoglobin is going to be split out of them, this hemoglobin is going to attract the nitric oxide with it, right? It's going to say, oh, nitrous oxide, let's come here, right? Nitrous oxide is going to come here with the hemoglobin, right? Nitrous oxide will come here with the hemoglobin. This is the first thing. So when nitrous oxide comes here with the hemoglobin, next thing that is important is that nitrous oxide is now gone because it attaches to the hemoglobin. So all of the blood vessels inside the body constrict, and whenever blood vessels constrict, there is platelet aggregation, there is formation of platelet and thrombi, right? Second thing that is that these patients then have hemoglobin also causes stress inside the body. If more hemoglobin is present outside, it's going to cause oxidative stress. When the body is going to have oxidative stress or any kind, whenever body goes through oxidative stress, it develops thrombi, right?
But doctor,
Okay.
why it attracts NO?
I'm not sure about that, right? Maybe there is some kind of I would have to see. It's more like biochemical stuff, right? It's like hemoglobin has affinity for some special proteins, and that's why it's maybe it attracts it, right? So okay, so yeah, that's right. Okay, so now
Dr.
this.
Maaz, I have a question, please. Nitric oxide is a vasodilator, right? It's not
Mhm.
vasodilator. So how is it here doing vasoconstriction?
It's not doing vasoconstriction, so we need an amount of vasodilation in our body every time, right? So nitric oxide, nitric oxide is gonna attach to is gonna get attached to. So just give me, I'll give you a basic example, right? So this is a way of body deceiving ourselves. So these things are deceiving ourselves, right? So for example, you are a very someone is a very famous celebrity, right? This is person A. He is a very famous celebrity, right? And he has five bodyguards, right? Oh no, he has one bodyguard, right? Or two bodyguards, right? So he have two bodyguards, and what happens is that these bodyguards are protecting him 24/7, right? Someone wants to kill this person. So what do? Is that they hire two girls, right? And then these two girls attract these bodyguards, which are the nitric oxide, right? And these bodyguards go on with the girl, right? So whenever, so basically they are attracting these bodyguards, right? These bodyguards are gonna go with them. This person is gonna be alone. This person is gonna get killed, right? So the same thing is happening in our body, right? So hemoglobin comes. Hemoglobin is like, oh hey, nitric oxide, how are you, right? And then it takes nitric oxide with it, right? And nitric oxide forgets to vasodilate everything because it's not present there anymore. It's present inside the hemoglobin, right? So whenever it's present inside the hemoglobin, right, it's not going to form any function of vasodilation. So the whole body is going to go to vasoconstriction, right? So basically, Dr. Sanna, it's mixed both. So we are doing intrinsic anemias right now. So intrinsic anemias means that there is some problem with the blood vessels in the with the red blood cells that is causing the hemolysis, right? Uh, Intrinsic hemolytic anemias, there is problem with the blood vessels that is causing all of these things, right? Now, one other thing that is important is what is the triad of, I told you most of them have a triad, right? The major triad of this is hemolytic anemia. The second one is, so hemolytic anemia. The second one is, in these patients, thrombosis. And the third one is all of their cell lines gets reduced, right? There are cell lines that are going to be reduced, so there's going to be anemia as well as thrombocytopenia as well as leukopenia as well. So please keep this picture in mind whenever a question of paroxysmal nocturnal hemoglobinuria comes to you. So basically they are going to give you a 35-year-old male or 40-year-old male who has problems in whenever he wakes up in the morning, he thinks his urine is funny. It is pinkish or reddish in color. This is the first thing that they say. So it's pinkish or reddish in color. And then they are gonna say that this patient is having thrombosis in the body as well, right? This patient is having hepatic thrombosis. Uh, then the third thing that they're gonna say is that this patient's blood size are all reduced. White blood cells, red blood cells, platelet, all of them are reduced. Not only red blood cells. So you are gonna be sure, okay, this patient is having paroxysmal nocturnal hemoglobinuria, right? What are the labs that we see in these patients? What are the labs that we need to see? The labs that we need to see are CD55 and CD59. Again, I told you CB55 is what? CD59 is membrane inhibitor of electrolysis. And 55 is DAF, which is known as the DAF, decay accelerating factors. Both of these will protect the red blood cells from complement. But when they are not present, complement is gonna be gone away. Right? Any questions in now?
What happens
No.
to the
Mm-hmm.
level of CD55 and 59?
Mm-hmm. Yes, so we'll check the level of CD55 and CD59, and it's gonna tell us okay what's happening. Okay.
And
Now
both of them,
let's
are they both types of GPI?
so basically if this is the red blood cell, right? This is the antenna that is the GPI. right? So they are the proteins that are attached to the antennas. Right?
Okay.
Clear?
Clear. And their major function is to prevent the red blood cells from
Yeah.
prevent complement from destroying our body's red cell. Is that correct?
Yes, exactly. So basically, they are the guards against the complement, right? The next one is G6PD deficiency.
Okay.
What is G6PD deficiency? Again, G6, so basically, if this is the red blood cell, we have a protein inside, which is known as an enzyme, which is known as a G6PD enzyme, glucose 6 phosphate dehydrogenase, right? These enzymes make a protein, which is known as the NADPH, right? What is the function of NADPH, right? Function of NADPH is that we have another protein inside the red blood cell, which is known as the glutathione protein, right? So we have this glutathione protein in the red blood cells as well. So in G6PD deficiency, the levels of glutathione are going to be reduced, right? They are going to be reduced. Why? Because in G6PD deficiency, you cannot make NADPH. And NADPH as well may provide glutathione with the reserves, right? So glutathione reserves are going to increase when the patient is going to decrease when the patient is going to have G6PD deficiency. Why is this important? This is important because uh, all of the time our red blood cells and our body go through a lot of stress, which is known as the oxidative stress, right? So oxidative stress is the worst thing that can happen to our body. It literally destroys everything, right? It literally destroys everything. Right, so oxidative stress can be countered by glutathione in red blood cells. But whenever there is no more glutathione, red blood cells are gonna get destroyed whenever there is increased oxidative stress. Now comes the fact that when will the oxidative stress be increased? So the oxidative stress is increased during infections. So whenever these kinds of people come to you, they are gonna say that I had an upper respiratory tract infection 3 days ago, 4 days ago. I had a lower respiratory, lower urinary tract infection 3, 4 days ago, right? I have done abdominal pain, nausea, maybe appendicitis, right? And then they're gonna say, okay, so this is the things that these patients are gonna have, and then these patients are gonna have decreased amount of. So again, this happens inside the blood vessels, right? This happens inside the blood vessels, right? So when what is gonna happen is that this is gonna happen inside the blood vessels, and this patient again is going to come with hemoglobinuria or reddish or yellowish stools, yellowish urine, right? Reddish or orangish urine. Okay, this is the first thing that you are going to see, right? Now, but this is a
Doctor, can you please repeat what we will see?
we'll see him like red or yellow urine, right? Red or orange urine, right? Why? Because red, orange, or pink. Because again, this is an intravascular hemolysis, right? So whenever you are in intravascular hemolysis, the hemoglobin is gonna be secreted inside the, right. So hemoglobin is gonna be get secreted inside the blood vessels, right? Well, the hemoglobin is going to be secreted inside the blood vessels, right? Then you're going to see that this hemoglobin gets secreted into the urine, and these patients have hemoglobinuria or red or orange urine, right? Okay. So when is the oxidative stress in the body increase? One example is infections. The other example, two most important, are sulfur drugs. So any drug that contains sulfur, sulfamethoxazole, right? The most important one, right? And furosemide, etc. All of these are sulfur drugs. So these drugs are going. Whenever you take these drugs, then you are gonna see that whenever you take these drugs, and the patient is gonna have this problem. Okay, is that clear, guys? So again, if a person is taking anti-malarial, so they can give you that a person came from a trip 20-25 days ago, and now this patient is having so 2025. So this patient is having urine urine coloring, right? And this patient is having fatigue and pallor. So you decide to do an CBC. But when you do a CBC, you're gonna notice that certain things that will always be present. And what are those certain things that are always right? So basically, this is what you're gonna see, right? Now, so in G6PD deficiency, right? So sulfur drugs. So if a person comes from outside, especially from India, Pakistan, Bangladesh, or from Brazil, yeah, no, I'm not tired. I'm sorry. Yeah, no. So basically, in G6PD deficiency, what is gonna happen is that they are gonna give you a patient. The most important scenario is that this patient is gonna come from Bangla subcontinent, right? Subcontinent like Bangladesh, India, Pakistan, or this person can come from Brazil or South America, right? So any country of South America. These are the two places where this person can come from. And when this person comes from these two places, yeah, yeah, kind of Middle East, but malaria is more common in these three areas. Okay. So this person is gonna be taking anti-malarial drugs, right? So normally people don't and they know that they have G6PD deficiency all of their lives, right? They don't know this, but all of a sudden, whenever they are gonna take anti-malarial drugs or sulfur drugs or fava beans, then you're gonna see these patients have um G6PD deficiency, right? You're gonna The patients are gonna present with back pain, the patient is gonna have hemoglobinuria as well, right? And the most important thing is that you're gonna see that these patients show have RBCs with Heinz bodies and bite cells. So what are bite cells and Heinz bodies? Let's look at that. Hmm. So you're gonna have cells like this that are eaten from the middle. These are known as the bite cells, right? So these cells are eaten from the middle. So these are the bite cells, right? And then you're gonna have Heinz bodies as well. Let me show you of the Heinz bodies. So these are the Heinz bodies, right? So in Heinz bodies, you are gonna find. Let me show you a better picture. These bluish things are gonna be present inside the cells, right? So both of these conditions represent that this patient is having G6PD deficiency, right? So yes.
Dr. Mas, in G6PD deficiency, there occurs a cola colored urine.
Yes. So basically, every intravascular hemolysis is gonna have hemoglobinuria, and whenever you're gonna have hemoglobinuria, there's gonna be a color urine, right? You're exactly right.
Okay.
Okay.
The same in
So,
the HELP syndrome.
yes. Yeah. Again, in HELP syndrome, there is gonna be intravascular hemolysis, right? So whenever we go through all of these, I'm gonna tell you, okay, guys, is this intravascular? Is this extravascular, right? So basically, in order to sum it up, the pathophysiology, G6PD deficiency. Uh, Basically, first of all, they are gonna give you a patient. The patient is gonna have infection. The patient is gonna have use of anti-malarial drugs. The patient is gonna have use of sulfur drugs, and now this patient is gonna have abdominal pain, and the patient is gonna have anemia as well, jaundice as well, and the urine is gonna be dark due to hemoglobinuria. And then they're gonna ask you what is a pathophysiology. The pathophysiology is gonna be that NADPH is the rate limiting enzyme. It doesn't produce NADPH whenever there is no NADPH, right? What is gonna happen is that glutathione are gonna be reduced, and reduced glutathione is not gonna be functioned properly, right? So the patient is gonna have hemolysis, right? And what are the causes? Fava beans, antimalarials like chloroquines, pharmacoins, sulfur drugs like trimethoprim, sulfamethoxazole, like there are a lot. I'll mention I'll send you the sulfur drugs, right? And then infections as well, right? So how do you diagnose this? In order to diagnose it, it's very simple. You do a blood smear, and the blood smear will show Behind's bodies and bite cells, right? And then the last thing is that treatment. So the treatment is simple. You avoid the triggering agents, right? So okay, guys, we'll keep it till here today, right? And we'll start from tomorrow, or I think at after we can do it at after 12 hours also, right? Okay. Okay. Take care, guys. Bye bye.
Thank you.
You're welcome.
Thank you,
Bye.
doctor.
Dr. Moaz,
Yes, yes, yes.
sorry, I had a question.
Mm-hmm.
Can you broadly tell me how do we differentiate between like intravascular and extravascular hemolysis? These are the two basic categories, right?
Yeah, I'll tell you, in a good way. Wait. Thank you so much, Nurjan. Okay, I'll tell you in a good way. Okay. So basically, intravascular and extravascular, right? So first thing, whenever hemoglobin, this is the most important thing, right? Whenever red blood cells get destroyed inside the blood
Correct.
vessels,
Yes. Then it will be
hemoglobin,
intravascular.
yes, so hemoglobin is going to be increased
Okay.
inside the blood vessels, right? So whenever hemoglobin is increased, we have a protein which is known as the haptoglobin protein.
Yes. Yeah.
Haptoglobin protein, what does it do is that it goes and binds to the hemoglobin protein, right? So
Okay.
haptoglobin is going to bind to the hemoglobin, and these two are going to form a complex.
Yes.
This complex is going to get secreted in the urine.
Okay.
Okay. So basically, hemoglobin is going to be 100 times more than the haptoglobin. So what is going to reduce first, the hemoglobin or the haptoglobin?
They have to.
Haptog-
Yes.
Haptoglobin.
So in intravascular hemolysis, the most important marker is the haptoglobin protein. The
So it will be
haptoglobin
reduced
protein,
in intravascular.
yes, it's reduced in intravascular, right?
Right.
Second thing is that this patient, all the patients now hemoglobin is present and it's gonna go into the urine now, right?
Mm.
Because normally whenever a small amount of hemoglobin is released, this hemoglobin goes to bind with haptoglobin and nothing happens in the urine. But if a hemoglobin is increased so much, it's gonna go freely into the urine. It's gonna cause hemoglobinuria,
Mm.
right? It's gonna cause hemoglobinuria. There's gonna be hemoglobin in the urine, right? Right, so basically this is what is intravascular hemolysis. Just this fact that haptoglobin is going to be reduced and there's
Yeah.
going to be hemoglobinuria, you're going to make it, right? Now, extravascular hemolysis. In extravascular hemolysis, what happens is that red blood cells park themselves at the spleen, right? They come
Mm.
out of the spleen and then say, okay, sir, arrest me now, right?
Okay.
So what is going to happen is that they're going to go to the spleens, right? In spleens, RBCs, macrophages are going to destroy these
Mm.
RBCs. Macrophages are going to eat up these RBCs, and when macrophages are going to eat up these RBCs, the first thing that is going to happen is that there's going to be splenomegaly,
Mm.
right? Okay, so
Yeah.
there's going to be splenomegaly, no hemoglobinuria, and
Okay.
no coloring of urine, right? So
Got it.
basically, in intravascular hemolysis, hemoglobinuria and haptoglobin reduced, right, and color of urine. In extravascular hemolysis, splenomegaly and no changes in the color of urine, right, and
Got
no
it.
hemoglobin. Yeah, that's
And
it.
the main basically in extravascular hemolysis there's some intrinsic problem with the RBCs like the conditions like hereditary spherocytosis and all those things they are grouped in extravascular hemolysis, right?
In not in so in extravascular, so basically the main extravascular hemolysis that we have is the hereditary spherocytosis, right,
Yeah.
and autoimmune hemolytic anemia. Almost all of the other ones will be intravascular, right?
So in extravascular hemolysis there's these are genetic hereditary problems with the RBC morphology.
Yes, so basically, whenever there's problem with the morphology of RBCs,
Then
then
it's
it's most likely
extravascular.
extravascular,
Yes,
right?
that
Because they're
is what
gonna stay
happens.
in the spleen, right?
Exactly.
Okay, yeah,
And
So
that's
what
can you include then the sickled cell to this because it still has to do with the morphology of the red cell, red blood cell.
yeah, we can include the sickle cell in it as well. Sickle cell and also pyruvate kinase
yes,
deficiency,
yes.
right? In both of these, the red blood cells are very rigid, right? So sickle cell causes both extravascular and intravascular, but yes, it also causes extravascular. And same pyruvate kinase. We'll look into these tomorrow, and I'll tell you. Okay? I'll
And Dr.
matlab-
Moss, what were
Mhm.
you saying about the nitrous oxide thing? Was it it was with regards to intravascular hemolysis?
Yeah, so whenever there's intravascular hemolysis, hemoglobin is gonna be
Yeah,
increased, right? And this increased hemoglobin goes and binds to nitric oxide the same way. So first of all, it's gonna bind to haptoglobin.
yeah.
Haptoglobin, it's gonna bind to nitric oxide. Nitric oxide now is reduced in the whole of our body, right? And
Hmm.
when it's reduced in the whole of our body, right, we're gonna have problems, right?
Yeah.
So we're gonna have vasoconstriction. Okay.
Okay. All right. That's okay. Thank you so much.
Okay.
So
Okay.
does bilirubin play a role in this with in regards to intravascular and extravascular? Um is there increased in bilirubin with extravascular? Because
I didn't get your point.
I mean in regards to bilirubin, right? In intravascular hemolysis, would there be an increase in bilirubin concentration? Like
Yes. Yes. Yes.
What about extravascular? Does it
So basically bilirubin will increase in both. Okay.
both? Okay.
Yeah. Okay. It's not a specific marker.
It's not okay, it's not
Yeah.
specific.
It's
Okay.
for both, right? So the first things that I told you in the early time, like when we started the vascular, like hemolytic anemia. So every hemolytic anemia will have increased bilirubin. Okay. Everyone.
Okay.
Okay. Okay. Take care, guys. Bye.
Thank you.
You're welcome. Bye bye.
Thank you.
Bye.